When working up a patient with suspected multiple sclerosis, navigating the broad landscape of clinical mimics is arguably our most critical task, as misdiagnosis carries significant long-term prognostic and therapeutic consequences. The differential diagnosis can be systematically organized into 5 distinct pathological categories to help guide our diagnostic reasoning. By categorizing these mimics, we can strategically deploy targeted laboratory panels and imaging to methodically rule out confounding conditions before arriving at a definitive MS diagnosis. Our first and most expansive category involves alternate inflammatory diseases that can closely mirror the demyelinating patterns of MOGs. Systemic autoimmune conditions, such as systemic lupus erythematosus, Sjögren disease, Behçet disease, and polyarteritis nodosa, frequently present with central nervous system involvement and must be differentiated via systemic serologies. Similarly, primary CNS vasculitis, such as granulomatous angiitis, and paraneoplastic encephalomyelopathies can manifest with multifocal neurological deficits. Within the neuro-inflammatory spectrum itself, we must distinguish MS from acute disseminated encephalomyelitis, ADEM, or post-infectious encephalomyelitis, as well as distinct antibody-mediated demyelinating diseases like neuromyelitis optica, NMO, and MOG antibody-associated disease, MOGAD, which require specific serum AQUAPORIN4 and MOG IgG assays. Next, we must aggressively rule out infectious diseases and granulomatous diseases, as initiating standard MS immunotherapies in these patients can be catastrophic. The infectious mimics include neuroborreliosis, Lyme disease, human immunodeficiency virus, HIV, infection, and progressive multifocal leukoencephalopathy, PML. Notably, human T-cell lymphotropic virus type 1, HTLV1, infection, PML, and neurosyphilis are predominantly important to differentiate in the setting of progressive disease. For granulomatous processes, sarcoidosis is a notorious great imitator that can present with parenchymal or meningeal lesions, alongside granulomatosis with polyangiitis and lymphomatoid granulomatosis, which necessitate chest imaging and specialized seromarkers. Finally, we must consider diseases of myelin and a miscellaneous cluster of structural, metabolic, and localized syndromes, particularly when evaluating progressive phenotypes. Inherited leukodystrophies, such as juvenile or adult metachromatic leukodystrophy and adrenomyeloleukodystrophy, represent primary myelin disorders that can mimic progressive MS tracks and are critical differentials in progressive presentations. Among the miscellaneous mimics, metabolic issues like vitamin B12 deficiency and genetic conditions like spinocerebellar disorders also warrant heightened clinical suspicion in progressive cases. Structural anomalies such as Arnold-Chiari malformation, alongside localized syndromes like isolated optic neuritis, cerebellitis, and brainstem encephalitis, round out our essential checklist, ensuring that no stone is left unturned in our diagnostic workup.